Good day. We begin our module now. This lecture on infectious disease, one of the core pillars of pathology and clinical medicine. This topic is not just about memorizing organisms. It's about understanding the dynamic interaction between a microbe and its host. How that interaction produces the pattern of disease we see in real patients. Here, I want you to think of infectious disease as a cause and effect system. What does the microbe do? How it enters, spreads, evades immunity, and damages tissue. How does the host respond? Through inflammation, immune activation, repair, or sometimes immune-mediated injury. What pattern of injury result? Suppuration, granuloma, necrosis, cytopathic changes, or chronic inflammation. How do these mechanisms explain clinical findings? Fever, organ dysfunction, rashes, lymphadenopathy, respiratory compromise, or systemic complication. Understanding microbial pathogenesis gives you the ability to interpret clinical presentation. Not just name them, it helps you connect the mechanism to the morphology, to the clinical manifestation, to the complication. This is the foundation for diagnosing infections, anticipating complication, and understanding why different pathogens produce distinct pattern of disease. So, by the end of this lecture, you should be able to look at the patient's symptoms, lab results, or tissue biopsy, and reason through how the infection produced those findings, not just what the infection is. This mechanistic thinking is what elevates you from memorizing the facts to practicing real clinical reasoning. So these are my contents, and these are my learning objectives. Let's begin. So this is the major step in microbial pathogenesis. How organisms enter the body, how they spread, how they damage tissue, and why disease severity varies from patient to patient. Number one, the entry. How microbes get into the host. Microbes must first breach a barrier to establish infection. Each portal of entry is associated with characteristic pathogens and skin diseases and disease pattern. First, the skin usually requires break in the barrier. Think of staph aureus, wounds, burns, and IV lines. Next, respiratory tract, the most common entry point, viruses like the Mycobacterium tuberculosis or the fungi. Gastrointestinal tract, acid-resistant organism or those protected by food, cholera, salmonella, or norovirus. Urogenital tract, like the sexually transmitted infection ascending UTIs. Entry determines the initial site of replication and often the early clinical manifestation. The spread, localized versus systemic infection. After entry, microbes may remain localized or disseminate systemically. Local spread confined to the entry site, like the cellulitis, localized abscess. Systemic spread via lymphatics, bloodstream or nerves, sepsis, viremia, neurotropic viruses. The ability to spread depends on the microbial factor, the motility, enzyme, immune evasion, and host barriers. Mechanism of tissue injury. Microbe cause disease through the three major mechanisms. Direct injury, viruses causing cytopathic effects, intracellular bacteria disrupting cell function. Toxins, the exotoxin like diphtheria toxin, cholera toxin. directly damage or dysregulate cells. Endotoxin, LPS, triggers systemic inflammation and shock. Immune-mediated damage, like excessive inflammation, immune complex deposition, autoimmune reaction triggered by infection, rheumatic fever. Often, the host responses causes more damage than the microbe itself, especially in viral infection. The outcome, virulence versus host immunity. The final clinical picture depends on the balance between pathogen virulence, toxins invasiveness, immune evasion strategies, host immunity, age, genetics, comorbidities, vaccination status, immunosuppression. The same pathogen can cause mild disease in one patient and life-threatening illness in another, depending on this balance. So, this highlights the dynamic relationship between the invading microbes and the host immune system. Disease does not result from the pathogen alone. It emerges from the interaction between microbial strategies and host defenses. Innate immunity, the first line of defense. Before adaptive immune system even activates, the body relies on innate mechanism to block or neutralize pathogen. Physical and chemical barriers, skin, mucous membrane, gastric acid, antimicrobial peptides. Phagocytes, neutrophils and macrophages, rapidly ingest and kill microbes. Complement system, opsonization, membrane attack complex, and inflammation. Innate immunity acts within minutes, and its effectiveness often determines whether an infection becomes established. 2. Adaptive immunity. This is targeted, specific defense. If microbes bypass innate defenses, the adaptive immune system provides a more specialized response. Antibodies neutralize toxins, block viral entry, opsonize bacteria, activate complement T cells. CD4 positive T cells coordinate immune responses and activate macrophages. CD8 positive cytotoxic T cells kills infected cells, especially in viral infection. Adaptive immunity is slower to activate but provides memory, which is the basis of vaccination. Immune evasion, how pathogen outsmart the host. Pathogen evolve sophisticated strategies to survive despite immune pressure. Antigenic variation, changing surface protein. Influenza, HIV, trypanosomes. The latency remaining dormant inside the host cells, like herpes virus and TB. Inhibition of phagocytosis. Capsules, biofilms, or toxins that disable phagocytes. Intracellular survival, hiding within the macrophage or epithelial cell to avoid antibodies. This evasion mechanism allows microbes to persist, spread, or cause chronic recurrent disease. Next, the microbial virulence factor. Virulence factor determines how aggressively a pathogen can invade or damage tissue, adhesins for attachment, enzymes that break down tissue, toxins that disrupt cell function, mechanisms that suppress, manipulate immunity. The more virulence factor a pathogen possesses, the more severe the potential disease. Next is the balance. Determines the disease severity. Ultimately, the clinical outcome reflects the tug of war between microbial aggression, the virulence, replication rate, immune evasion, host defense, innate barriers, immune competence, prior immunity. A highly virulent pathogen can overwhelm even a healthy host, while an immunocompromised patient may suffer severe disease from organisms that are normally harmless. So, pathogens survive by evading or manipulating the immune system and the host response with the layered defense. The severity of infection depends on which side gains the upper hand. So, mechanisms of bacterial injury. The major way the bacteria cause tissue damage. Bacterial injury is not due to single mechanism. It's a combination of toxins, inflammation, immune evasion, each contributing to the clinical pictures. Exotoxin, highly specific potent bacterial weapon. Exotoxin are secreted proteins that acts on specific target. They explain many of the dramatic clinical syndromes seen in bacterial infection. Neurotoxin interfere with neurotransmission. The tetanus toxin cause spastic paralysis. Botulinum toxin cause flaccid paralysis. Enterotoxin acts on the GI tract, causes watery diarrhea in cholera or food poisoning in Staph aureus and Bacillus cereus. Cytotoxin directly kills host cell. Diphtheria toxin halts protein synthesis. Shiga toxin damages endothelial cell, leading to HUS. Exotoxin often produce rapid severe symptoms, even when bacterial numbers are low. Endotoxin LPS, the driver of systemic inflammation and shock. Endotoxin is a component of outer membrane gram-negative bacteria. When released, LPS triggers massive cytokine release, TNF and IL-1, which cause fever, hypotension, disseminated intravascular coagulation, and septic shock. This is why gram-negative cysts can deteriorate quickly. The host inflammatory response becomes overwhelming and damaging. Inflammation-mediated injury. The host attempts to eliminate bacteria can itself cause tissue destruction. Suppurative inflammation. Neutrophil-rich pus typical pyogenic bacteria like staph and strep. Necrotizing inflammation. Toxins and enzyme causing tissue death seen in necrotizing fasciitis. Chronic inflammation, persistent organism lead to fibrosis and scarring. In many infections, the immune response causes more damage than the bacteria themselves. Immune evasion, how bacteria persist and spread. Some bacteria avoids immune clearance, allowing prolonged infection and greater tissue injury. The capsule prevents phagocytosis like in S. pneumonia or H. influenza. Biofilms protect bacteria on surface like catheter prosthetic bulbs. Intracellular survival. Organisms like Listeria and Mycobacterium hide inside macrophages. Immune evasion prolongs infection, increases inflammation, and raises the risk of complication. So bacteria injure tissue through toxins, inflammation, and immune evasion. LPS, lipopolysaccharide, is especially dangerous because it can trigger a systemic cytokine storm, leading to septic shock. Mechanism of viral injury. The major ways viruses damage host tissue. Unlike bacteria, viruses rely entirely on host cells for replication. So much of the injury comes from how they manipulate or destroy those cells, or how the immune system reacts to them. Direct cytopathic effect. Many viruses cause injury simply by replicating inside host cell and disrupting normal cellular function. They hijack host machinery, shutting down protein synthesis. Viral replication can cause cell lysis, membrane damage, or syncytia formation. Some viruses induce apoptosis as part of their life cycle. This direct effect explain the classic cytopathic changes seen in histology, inclusion bodies, multinucleated giant cells, or ballooning degeneration. Immune-mediated injury. In many viral infection, host immune responses causes more damage than the virus itself. Cytotoxic CD8. T cells kills infected cells to stop viral spread. This is protective but can lead to significant tissue injury. For example, in viral hepatitis, immune complex deposition can occur in chronic infection causing vasculitis or glomerulonephritis. This mechanism explains why symptoms often worsen when the immune response peaks. Latency. Viral persistence without active replication. Some viruses establish latent infection, remaining dormant for years. HSV and VZV hide in sensory ganglia. They reactivate during stress or immunosuppression, causing recurrent lesion or shingles. Latency allows lifelong persistence and periodic tissue injury. Latency is a key survival strategy that helps virus evade immune clearance. Next, the oncogenic virus, integration and transformation. Certain virus contributes to cancer development by altering host cells growth regulation. HPV integrates into host DNA and inactivates tumor suppressor, the P53 and the RB. EBV drives B-cell proliferation and is linked to Burkitt's lymphoma and nasopharyngeal carcinoma. HBV and HCV cause chronic inflammation and genomic instability, increasing hepatocellular carcinoma risk. Oncogenic viruses do not cause cancer immediately. It is the long-term interaction between viral genes and host cells that leads to transformation. So viruses injure tissue through direct cytopathic effects, immune-mediated destruction, and long-term persistence. Some integrates into host DNA and contributes to oncogenesis, highlighting how viral infection can have both immediate and lifelong consequences. So fungal and parasitic infection, fungal and parasite cause disease, emphasizing their unique mechanism of injury and the clinical pattern they produce. Unlike bacteria and viruses, these organisms often cause chronic, indolent, and opportunistic infections that reflects both pathogen, biology, and host immune status. Fungal infection, opportunistic, chronic, and often severe in immunocompromised hosts. Fungi are eukaryotic organisms, so they tend to cause disease when host defenses are weakened. Opportunistic infections, Candida causes mucocutaneous infection but can become invasive in neutropenic or ICU patient. Aspergillus invades blood cells or blood vessels, causing hemorrhage and necrosis, especially in transplant or leukemia patient. Granulomas, many systemic fungi like the histoplasma trigger granulomatous inflammation similar to TB. Granulomas reflect a cell-mediated immune response attempting to contain persistent organism. Tissue necrosis. Some fungi, especially mucor and aspergillosis, cause angioinvasion, leading to infarction and necrotic lesion. Fungal disease severity tied to host immunity, particularly neutrophil function and T-cell mediated responses. Parasitic infection, tissue damage, immune evasion, and chronic inflammation. Parasites include protozoa and helminths, each producing distinct pattern of injury. Tissue destruction, the plasmodium destroyed the red blood cells, leading to anemia and microvascular obstruction. Entamoeba histolytica causes flash-shaped ulcer in liver and abscesses. Immune evasion, parasites often alter surface antigen, hide within host cells, or modulate immune response. Helminths secretes molecules that suppresses immunity, allowing long-term survival. Chronic inflammation, persistent parasitic inflammation lead to fibrosis, organ enlargement, and long-term morbidity. Helminths can cause eosinophilia, granuloma, and obstructive disease. An example is the schistosoma. So this mechanism explains why parasitic disease are often chronic, relapsing, and associated with nutritional deficiencies and organ damage. Some key examples to highlight this infection. Candida, mucosal infection, invasive candidiasis in immunocompromised patient. Aspergillus, allergic bronchopulmonary aspergillosis, invasive aspergillosis. Malaria, hemolysis, anemia, cerebral malaria, due to microvascular sequestration. Helminths, chronic inflammation, malnutrition, anemia, organ obstruction. This example helps students connect mechanism to real clinical syndrome. So fungi primarily causes disease in immunocompromised hosts through granulomas and necrosis, while parasites produce chronic inflammation, anemia, and organ damage through immune evasion and persistent tissue injury. So patterns of tissue response, this summarize the major morphologic patterns of body produces in response to infectious reagent. Recognizing this pattern helps you to connect mechanism, morphology, and clinical presentation, which is the core pathology reasoning. Number one, suppurative inflammation, neutrophils, abscess formation, pyogenic bacteria such as Staphylococcus aureus, the Streptococcus pyogenes trigger a neutrophil-rich response. Neutrophil accumulates rapidly at the site of infection. Enzymes released from dying neutrophils and bacteria cause liquefactive necrosis, forming pus. When localized, this becomes an abscess, a walled-off cavity filled with neutrophils and debris. Clinically, this corresponds to painful, warm, fluctuant lesions or purulent radish. Granulomatous inflammation, TB fungi, or certain parasites. Granuloma form when the immune system attempts to contain persistent, hard to eradicate organism driven by T-cell mediated immunity and activated macrophages. Classic example is cacheating granulomas in tuberculosis, with central necrosis surrounded by epithelioid cells and giant cells. Fungal infection like histoplasma or coccidioides also produce granuloma. Granuloma reflects a chronic organized immune response rather than acute inflammation. Necrotizing inflammation, some pathogens cause rapid destructive tissue necrosis due to toxins, vascular invasion, or overwhelming inflammation seen in necrotizing fasciitis. Strep pyogenes, mucormycosis, and severe bacterial pneumonias. Tissue destruction is often disproportionate to the number of organisms present. This pattern is clinically aggressive and often requires urgent intervention. Chronic inflammation and fibrosis. Persistent infection can lead to long-standing inflammation, tissue remodeling, and scarring. Chronic viral infection like the hepatitis B or C leads to fibrosis and cirrhosis. Parasitic infection and some fungal disease cause prolonged immune activation and collagen deposition. Fibrosis represents the body to attempt to repair damage but can lead to loss of organ functioning. Integrating pattern with pathogens. Different pathogens produce signature morphologic pattern. TB producing cacheating granuloma, pyogenic bacteria producing abscess, viruses produces cytopathic changes and inclusion body, fungi produces granuloma and necrotizing lesion, helminths produces eosinophil-rich chronic inflammation. So recognizing this pattern helps you predict the likely pathogen and understand the clinical consequence. So each pathogen triggers a characteristic tissue response from neutrophilic abscess to granulomas and necrosis. And this pattern are essentially clues for diagnosis and understanding disease mechanism. So clinical correlation. So this slide ties together everything we discussed by showing how specific pathogens produce characteristic patterns of injury and clinical manifestation. Each example illustrates the link between mechanism, tissue response, clinical disease, which is the core of pathology reason. Number one, tuberculosis, TB, granulomas and caseous necrosis. TB is the classic example of granulomatous inflammation driven by a strong T-cell mediated immune response. Mycobacterium tuberculosis survives inside macrophages, triggering chronic inflammation. The immune system forms cacheating granulomas to contain the infection. Central necrosis gives the cheese-like appearance. Clinically, this explains chronic cough, cavitary lesion, and systemic symptoms like weight loss. TB demonstrates how persistent intracellular pathogen lead to granuloma formation. Number 2, viral hepatitis, hepatocyte injury and fibrosis. Hepatitis virus, HBV, HCV, causes injury through both direct viral effect and immune-mediated cytotoxicity. CD8 plus T cells kill infected hepatocytes, producing ballooning degeneration and apoptosis. Chronic inflammation leads to fibrosis, architectural distortion, and eventually cirrhosis. This explains elevated liver enzymes, jaundice, and long-term risk of hepatocellular carcinoma. Viral hepatitis show how immune-mediated injury can drive chronic organ damage. Next, number 3, malaria. Hemolysis and splenomegaly, Plasmodium to endothelium, leading to mass microvascular obstruction, especially in cerebral malaria. The spleen enlarges due to increased clearance of damaged RBC and immune activation. Malaria illustrates how parasitic replication inside host cell produces systemic disease. Number 4, HIV. The opportunistic infection and CD4 plus T cell depletion. HIV targets CD4 plus T cells, progressively weakening cell-mediated immunity. Loss of CD4 plus cells impairs the ability to control viruses, fungi, and intracellular bacteria. Patients become susceptible to opportunistic infections such as pneumocystis, pneumonia, candidiasis, and TB. Chronic immune activation also contributes to the wasting and malignancies like Kaposi sarcoma. HIV demonstrates how immune system collapse leads to secondary infection rather than direct viral injury. To summarize everything, this clinical example show how microbial mechanism from granuloma formation to immune-mediated injury and cell destruction translate into and treat. So, if you have questions, so infection is the price we pay for being multicellular by Gregory House in House MD. These are my references, and thank you.